I can't plan to have a behavioral health crisis next Thursday at 2:00, but that's when my appointment is. And so we really need to be more on-demand care at the lower levels of care, because what happens today is you're having a crisis. If you can't get into your outpatient provider, you're going to the emergency room. I honestly think it's meeting people where they are with what they want, what the level of service they want. We often talk about access and percentage of patients seen within X days, but I'm really more interested in, did you get care when you needed? If you were having that crisis, were we able to meet you where you are? Even if it's in home through virtual care, were we able to meet you where you are? So really a consumer-driven model for behavioral health care versus kind of a structural model that's historic.
Welcome to another Meeting of the Minds with Wobot Health. I'm your host, Chris Hemphill, and I gotta say, we're really excited about this podcast partnership that we have with Future of Mental Health Summit, because we're bringing a lot of the conversations that unfortunately happen behind closed doors and in these rooms and everything like that. But the podcasts and video just gives an opportunity to go in depth in a way that you can't necessarily explore on a panel. So the subject that we'll be focusing on today is on rural care and driving access. Even if you don't serve a rural population, don't turn away. Don't click next on the video, next podcast, because there's a lot of lessons that Dawn from Geisinger Health brings to the table that I think apply broadly across all organizations. So Dawn, I get to brag on you. So you don't have to do it yourself if you don't want to, but I get to brag on you that Dawn Zieger from Geisinger Health, who is the VP of Psychiatry and Behavioral Health. And just to a note on what we'll be talking about, driving behavioral health access for rural care. Imagine that you've overcome barriers like stigma and cost, and you're excited to have some sort of avenue to access care, but the nearest solution is 30 miles away, or is just completely unavailable to you because of waiting lists and all kinds of other issues that are these impediments that, as patients, we don't really think about or prepare for. So Dawn, she's uniquely prepared to talk about this conversation because of her work at Geisinger to smash down those barriers and make rural care available. So Dawn, would you mind just giving the audience an intro to Geisinger and your work as it applies to behavioral health and access?
Yeah, absolutely. So at Geisinger, we have a full continuum of care for mental health and substance use disorder. I'm really excited to be the operational lead for these services. We get to bring services into communities that there are not other healthcare providers or behavioral healthcare providers. In my role, we've expanded virtual care tremendously. We added 74 providers in 2 years, which seemed like a great idea till I realized they were all showing up and I needed to be ready. So we've rapidly scaled behavioral health services. We did 116,000 virtual visits this last year. So the neat thing about it is we're bringing resources from urban communities where people want to live into rural Pennsylvania where there literally aren't other options. So really proud to be at Geisinger, working on the full continuum. So it's not just those outpatient visits, it's also inpatient, intensive outpatient programs, and so we're growing on every front.
Thank you for that intro, and for the audience, I hope that you hang on to some certain words that you're hearing, because we're talking about like the overall blip buzzword is rural care access, but behind that are workforce issues,
Yes.
technology issues, and areas where you can guide people to the right kind of care, right?
Right. Absolutely. And in the workforce front, we're really lucky to have a medical school. So we have a program called the Abigail Geisinger Scholars, where if people choose to serve in psychiatry and stay in our community, their medical school is paid for. So we're trying to work on the immediate front with virtual care while we develop workforce in psychiatry, psychology, and social work.
So let's think about this too, because there's a whole lot of topics, a whole lot of stuff that we can talk about, and maybe some of it's overwhelming to some people and everything like that. You can just watch the video again, just watch it on repeat. But Dawn, somebody listening, somebody said there's a reason that brought you here other than me emailing you over and over again. What's the one thing that you would want someone to come away from this conversation with?
Well, I first want you to think about your network. I want you to think about your religious community, your family, the people in your neighborhood, and then think about the fact that 1 in 5 will experience a mental health issue in a given year. And about half of those folks don't get access to care for one reason or another, whether it's stigma or wait time. So mental health is all of our business. It's not just my business in behavioral health. Every health services organization is impacted by this.
So, Don, thank you for sharing that. And you're going to hear that peppered throughout the conversation. We'll be referring to that. Don, I'm actually not done bragging on you.
Oh.
So there's a lot of positivity, a lot of energy that you bring, and it just makes me want to get into your personal background. Like there's a path that we normally see in the VP of behavioral health type role, where there's often like a clinical backing and everything like that. But it's a different path on your perspective. I just wanted to comment on your service in the military with the being a Patriot missile crew member, community development work in Vietnam, work with the unhoused, all the way into this leadership role that you have at Geisinger today. So can you talk about the experiences of the past and how they relate to what you're doing today?
Oh, absolutely. So some people have a career ladder. I have a career lattice. I've been a little bit over here, a little bit over there. And while some people climbed quicker because it was a more direct route, I feel like my experience has been very much enriched by getting to see different domains of society. Working in the military, somebody says my only tell is when it gets chaotic, I calm down and lock in, and I can manage a crisis situation pretty readily. From a community development standpoint, that's actually how I got into healthcare. So we were traveling to Vietnam to serve individuals that were minority people groups and didn't have the resources. And I got lost one day and I ended up in the homeless area in Fort Worth, Texas. And I sat in my car and I just cried. I said, could I ever help these folks with my skill set? Not a hot dog and a t-shirt. Like, could I ever really help? So I ended up working in homeless healthcare for a few years, which got me into behavioral health care.
Wow.
And so I really love that I got to learn the whole system. I've worked in primary care. I've worked in scheduling. I've worked in IT for 10 years. And so I bring a breadth of knowledge that's really fun to problem solve because I've got a lot of tools in my tool belt. And so I do a lot of mentoring of young leaders, and everybody's looking for the right next thing. And sometimes you just got to let life unfold and take that next right step.
So I'm hearing a lot about this professional background that leads into behavioral health, and what an amazing way to look at the crisis that's happening with the unhoused and the homeless. And a lot of people resort to blame and stigma and everything like that. But hey, like, what's actually the root cause of this? But as much as you're comfortable sharing, could you share your why and like what's led you down this passion for behavioral health too?
Yeah, absolutely. I think I have a really hard job, and it's my dream job. And let me tell you why. So I have 3 aunts and uncles that had schizophrenia that were in state hospitals off and on their whole life. I have a father with bipolar who struggled with addiction. And when he got treatment, the second half of his life, he was a totally different person than before he was treated. And then I'm blessed myself to have bipolar disorder and to really understand what it's like to struggle some days. And some days, boy, the hypomania really helped me be successful. And so now I'm at a point in life where I'm really seeking balance. And I'm grateful to have a mental illness so that I can have compassion that I don't know that I'd otherwise have.
Well, I really appreciate the way that you share that story, because it's framed in a way of, hey, given who I am, given what like the way that I function, how do I make that work for me, and how do I live with myself comfortably?
Yeah, and it's fun. I love that I like to problem solve. I see things in a different way. I had an employee come to me. She was so funny. After I worked with her 10 years, she goes, I know, if you change step 22, it's going to affect step 57. And I trust you, but you need to tell me why. And so I've had to learn how to relate the way that I think to other people. But man, the more context I pick up through all these different jobs, the more that I learn to apply things from other domains. So a lot of what we're doing with behavioral health is lifted from primary care, patient-centered medical home, experiences working in manufacturing, thinking about input and output and what's quality. And so I kind of feel like I have this knowledge mashup that makes my life pretty fun these days.
Well, thank you for sharing. And honestly, like you shared your one thing that you want people to get out of the episode. my other thing, like I had an ulterior motive too, is for people to see that it doesn't have to be what's called the regular way. Like
No.
there's all kinds of different paths and all kinds of different people that make it, and we're not just in a one mold world anymore.
And if I can say one more thing, I got my bachelor's degree when I was a mom. I was a working professional. My daughter was 3 when I graduated. I got my master's degree when my son was 3. And so it can be done. Like, it's never too late for you to pursue education or pursue your interests. It's been really fulfilling to be able to do that as I work, of course, with the support of my husband who manages the fort.
So, and like everybody, like, stay on that. I'm happy to spread that message about what you can do, and how the burdens that you perceive might not actually be burdens. Now, earlier in the conversation, you shed some light on the population that Geisinger serves. You said in the middle of nowhere, so we know, like, rural population and things like that.
Maybe that wasn't nice.
Oops, edit that out. But could you talk about, like, given where Geisinger is and the unique challenges of the rural population, can you talk about what's the status quo for rural care and some of the gaps that you see from this behavioral health perspective?
Yeah, absolutely. So we've got a very large service area in central Pennsylvania. 2 of our counties are urban, the rest are rural. So we started out as a department in 2015, this is before I came, with 26 providers. We were very hospital-based. If you came to us with a mental health crisis, we were going to do a great job treating you. We did not have as much outpatient services, intensive outpatient, which is a full-day service. So since that time, we've grown to 167 providers because we're really trying to bolster the full continuum of care. So that we can meet you where you are. If you're in crisis, we absolutely want to meet you there. If you're escalating and you're having a hard time, maybe we need to see you more often in a full day program. Or if you're kind of stabilized, maybe we go to once a month, but we want to meet our patients where they are. The other challenge with rural is in some of our communities, there's literally no psychiatrist. It used to be we had 1 child psychiatrist. We now have 13. And so we had to say, stop hiring child psychiatrists, but it's because we were offering a very compelling employment opportunity for people to work virtually and then impact communities that really needed them.
So, like, we're talking about behavioral health, but I wonder, this is a conversation we've been having a lot at the conference at Future of Mental Health, is how does behavioral health fit into the overall strategy? Like, is it separate, or are we looking at something that's across that's integrated into the rest of the domain?
Oh my gosh, this is what I'm so excited about working at Geisinger. I love that we think about whole person care. So you can't take the head from the body, treat the head. We're our one person. And so I think the real opportunity for us is to partner more closely with primary care, is to partner more closely with our emergency department. So let's just pretend I'm a patient that has diabetes. I might be treated by an endocrinologist. I might be treated by primary care. I might be seen by a psychologist. And if that isn't coordinated, maybe we've got different goals in each situation. So having behavioral health as a part of integrated care allows us to treat the whole person, have a shared treatment plan that respects what are you trying to accomplish, and helps us to do that together. Real quick story about my dad. He had health issues, and at the end of his life, his quality of life was determined by how often he got in the garden. It wasn't anything else. It wasn't his oxygen levels. It wasn't any of that. It was how often did I get in the garden. And so really listening to our patients and what determines their quality of life is really where we want to be.
That when we listen to patients and when we listen to and process actual stories, I think that does make a huge difference versus what people call medicalizing and reducing down to, like, specific numbers, metrics, and scores. How do you, at the population level, how do you identify those quality of life issues?
Gosh, I think that's the trick. That's why we're here talking about the future of mental health care, because I don't know that we do a very good job at it. I think the opportunity we have as behavioral health is to grow from individualized care to panel-based care and proactively managing patients. So if I'd seen you in the past and you'd stabilized, and perhaps you showed up to the emergency department with a high depression screening, I want to be able to recognize that as your behavioral health provider and pull you back into care. At a population level, we want to really manage understanding if we're stabilizing people with depression in a particular market, that somebody can learn from someone else. So we really need to toggle up from that one-on-one piece to population level management.
So when we talk about the changes that Geisinger's undergone and the gaps that you brought up earlier about rural health, everything that I've read that you've been part of or speaking of, it's not looking at things piecemeal. There's always this structured approach that you're thinking about with it. I'd love for you to share that. There was one paper that was talking about 5 steps. I don't know if you know all of those off the top of your head, but what's the comprehensive approach that you recommend for a lot of these other organizations that are struggling with rural populations?
So I think it starts with the patient. So when I went to Texas and worked on homeless healthcare, I really didn't understand the continuum. So I spent a lot of time actually going into the woods, going into homeless shelters, and asking people how they experience the mental health system. In my office, I had walls and walls of process steps and what people said was working, what wasn't working. And so I think it has to start with the patient. And then think about what your product is. In manufacturing terms, what's your inputs to the process? What are you producing? How do you define quality? And what are the outputs? So we have to start with that basic process management approach, I think, to really be comprehensive. Just last week, we're redesigning outpatient care. So what we did is we took the workflows that we had built on the wall and we had people walk the workflows. So we kind of played the game of life with transitioning through behavioral health services. And just by walking in the patient's shoes, we found 3 major gaps in our design as we tried to envision a patient accessing care. So I really think it gets back to the basics of process mapping and taking the process apart.
Would you mind going a little bit deeper on that, walking in that journey, like how that exercise went, who's involved, and basically what are some of the steps that you saw?
Yeah, it started with a year and a half ago where we walked in our patient's shoes. We gave different patient scenarios and we had people enter through different doors. And what we found is unintentionally, we'd created a system where people got different access with the same scenario based on the door they walked in. And so that really got our team ready for change. So this last exercise was the culmination of us redesigning our care. And so literally we had clinicians, ops managers, and directors literally walk through, I have a substance use disorder and I'm presenting to the emergency department. What's next? What's next? And so through that, we found some gaps that we're going to be working through as a team.
Great. And it sounds fairly recent, but I wonder about, I guess, some of the outputs, or has any of the work started from that exercise? Or
Yeah, on a larger scale, we're reorganizing everything we're doing with outpatient. So we see virtual care as a strategic opportunity, not just a Band-Aid, particularly in our rural market. So what we're going to be doing is taking these virtual providers that today might be in Texas, California, Illinois, and they might see anybody in our service area. We're basically regionalizing them with the on-the-ground resources. So we have primary care providers with behavioral health specialists in each of our communities. Mm-hmm. They can be the hands and feet on the ground, and then we're going to build a backbone of virtual care. So those virtual care providers get to know the schools, they get to know the primary care providers, and it feels like more of a fluid experience instead of an outsourced psychiatry service. So this restructure is going to be great, not only for building trust with primary care, but building camaraderie in a virtual care environment. I mean, we can't stop at the water cooler. We don't have pizza day on Fridays because everybody's at home. Mm-hmm. And we don't want that isolation to creep in on our providers. So I'm super excited about this next turn. It's based on a Harvard Business Review article, The Strategy That Will Fix Healthcare, and really bringing multidisciplinary teams together.
Wow. Okay. We definitely need to link to that. I'm saying we need to link to that article and show it up on the screen. It makes me curious too. I know that there's been work that has had an impact on like wait lists and wait times and things like that. How does that relate into that picture?
Ooh, okay. So we started out with a backlog of 18,000 patients that were referred to services. We hired 74 providers. We got it down to 3,000, and we were starting to see people more timely. And then as the panels filled up, that wait list creeped up again. And so where we're at right now is thank you for the growth. Growth is not a strategy. How do we do this differently? Which is leading us down exploration of things like the strategy that'll fix healthcare. So the other thing we did is those 18,000 referrals, people didn't know if they needed therapy. They didn't know if they needed med management. We had speech therapy referrals, all kinds of things. So we implemented an intake assessment to sort that out and try to figure out how to direct people to care. Now that we've done that with humans, we're going to build the tech on top. So 80% of our referrals can end up at the right destination without a human intervention.
Wow, let's talk about the tech. Let's talk about some of the innovations that are coming down the pipeline.
Okay, I'm super excited about one that just went live last week. We're utilizing
all ears.
Okay, we're utilizing robotic processing, which is almost like in the old school days an Excel macro, like repeatable things. But what we're doing is we're following the natural progression of a provider. So if you're my provider and you say, Dawn, I'd like to see you back in 30 days, that means we're established for the long term, right? So automatically, you're going to be on my care team, effective dated at that day, until you say, gosh, Dawn, you're stabilized, you can return to primary care. Then we remove that care team affiliation. It doesn't seem like a big deal. But what it's actually doing is allowing us to manage panels of patients over time. It's allowing us to have a great data point to say, gosh, Dawn just kind of drifted off and didn't end up in care. I need to pull you back into care. And then it's foundational for our value-based care strategy to be able to measure at the individual provider level and at the team level how your patient population is doing.
You're making me think about this this doctor. I believe there's a place called Cambia, but his name is Dr. Navdeep Kaur.
Oh, don't know him. I have to look him up.
Look him up because he said something that I'll never forget, which was access does not equal quality.
Yeah.
And it just like what you shared about, hey, let's use this technology to identify the right places to send people to. That's where that quality picture comes in, right?
Well, can I challenge that though?
Please.
You can't have quality without access. What are you going to measure if you don't have access?
Exactly. So yeah, need both, but I just it triggered that thought from the past. As we think about as we look at these solutions and how they work together, we've been talking about the results kind of piecemeal. I wonder if there's is there a way that when you're communicating to leadership that y'all come together and there's metrics and different things like that you review to make sure that these programs have life? Like what's the overall management and leadership guidance that you provide here?
Well, I'd say it's a little bit underway. We've grown as a team really dramatically. So one of the things that we've established within our department is a leadership council. That's all of our top leaders. We do leadership skill building. We've done retreats and those kinds of things. Secondly, we have service delivery council, which is all of our services coming together, talking about their challenges, where are they doing well on the metrics, where do they need to improve, and then us learning to work as a continuum. Because often behavioral health can seem transactional, particularly let's just take a consult service where you're in the emergency department, you're having a behavioral health issue, inpatient or outpatient. It seems like a binary thing, but it's really not. We've got to look at that patient in the context of, have they engaged in outpatient care? What's causing the ED visit today? How can we partner with outpatient services and consult services to stabilize the patient? So I think that's probably the biggest opportunity for us, is to really work as a continuum together now that we have a continuum of services.
So it's not just a bunch of numbers on a dashboard, it's conversations that are happening.
Absolutely.
Yeah,
Absolutely.
So you've talked about a lot of technologies. You've talked about a lot of pathways to innovation. I'm curious about either what you're hopeful, like what you think is going to be coming in the next 1, 2, 3 years, or what you'd be excited to see, what kinds of gaps you would like for innovation or technology to help fill.
Yeah, I mean, there's a couple things that happen in the physical health space that don't happen in behavioral health. So I'll give you an example. In a hospital, you know your case mix index. How complex are the people that you have in-house? A lot of times on psych units, we'll hear it's high acuity unit, high acuity unit. How do we quantify that? And if we have higher acuity than another unit in our community, can the payers help us with the additional resourcing that we have? So I'd love to see some algorithm and data science put behind characterization of our patients. The other thing I would love to do is—
So just to
go ahead.
make sure, so the gap, we hear a lot about measurement-based care, but overall the gap is, it's hard to know how to prioritize and how to understand who needs to go where, and just wanted to make sure.
No, you're good. And even staffing and ratios. So if you have somebody in an inpatient psychiatric unit and they have 2 sitters for 1 patient, that's an acute situation. And so being able to go back to our payers and say, we're happy to care for this patient. This is what we're here for. Can you help us cover the costs? And so there's some things like that we'd like to do. The big dream for me is to have an algorithm that helps detect exacerbation of behavioral health conditions. The NYU ED algorithm, don't know if you're familiar with it, but what it does is when somebody shows up to the emergency room, it looks back and says, was that avoidable, non-avoidable? Was it urgent, not urgent? And guess what they do with mental health? They don't know what to do. So it's carved out. So wonderful work has really helped us in the physical health space. I'd like to find a way to have that characterization with behavioral health that we can help people before that exacerbation happens. And so, one thought would be to use machine learning to look at the characterization of people that have been struggling, that have exacerbated, and reverse engineer what are those factors so that we can intervene earlier and upstream in the process. That would be a big dream.
Overall, there's something in me that tells me that maybe patients would be really looking forward to a way to not have to go to like the same kind of high acuity treatment that there's an opening for people that want a lower frame of
They don't want to be in
care or
crisis.
response. Yeah, exactly.
Yeah, so, we also have to think about our delivery system. So back in the olden days, 20, 30 years ago, you used to plan to go to dinner on Thursday and you would make a reservation at Olive Garden. We don't do that anymore. Everything's fast casual, it's on the fly. But think about our healthcare system. I can't plan to have a behavioral health crisis next Thursday at 2:00, but that's when my appointment is. And so we really need to be more on-demand care at the lower levels of care. Because what happens today is you're having a crisis. If you can't get into your outpatient provider, you're going to the emergency room. And then think about the emergency room. You got buzzers going off, people running by. You've got another person in your room. It's loud. It's not the ideal place to be able to stabilize. So we want to avoid that situation. And I'm really excited about an empath unit that we're building. And so this is a zone of the emergency room where somebody having a behavioral health crisis can go. It's called a living room model. So it's open. We have chairs, we have games, we have activities, and opportunities to interface with a peer and a social worker to help try to calm and try to see if we can stabilize the patient before going to inpatient level of care. So I'm really proud we're going to be building an empath unit in one of our hospitals, a dedicated psychiatric zone in another hospital, because we can do it better. Like, not we can do it better in an arrogant way, but I think we can do better for our patients. And I'm so glad even to get the call to say, how can we do this better?
Well, it resonates and tracks because people want to have access to the right level of response given a condition. And if everybody's put into the same place that screams crisis, 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 then the people that are actually having the crisis can't be seen. And it's hard to know it's hard to distinguish between the two, to your earlier point.
And bigger than that, even when we have behavioral health patients in the emergency room and you have other medical patients waiting, there can be harm done there too. So as much as we can help and stabilize folks outside of the ED, that's what we want to do.
Excellent. Well, we're talking about what's on the horizon. Now you get the ability to create it. We actually have a magic wand lying around here.
Okay.
I'm going to hand it to you. I don't have it with me. We should get a physical magic wand to hand people.
I just need the tiara.
Yeah.
So, I honestly think it's meeting people where they are with what they want, what the level of service they want. We often talk about access and percentage of patients seen within X days, but I'm really more interested in, did you get care when you needed? If you were having that crisis, were we able to meet you where you are? Even if it's in home through virtual care, were we able to meet you where you are? So really a consumer-driven model for behavioral health care versus kind of a structural model that's historic.
So I fully support that concept, and I like the fact that you brought that to the table. I'm just going to say, I've been following Geisinger for a long time, ever since meeting Don Stanziano a while back, and I've just thought that there's been a lot of interesting innovations coming out of y'all's field. But it makes me wonder, with your position in healthcare and your opportunity to serve there, where do you go, or where do you seek information, leadership? What are some of the sources that you follow? Like you did mention Harvard Business Review earlier, but I'm curious about others too.
I mean, at this point, I'm looking outside of behavioral health because I'm all about adapting, and looking at structures that make sense. So obviously, Harvard Business Review, love that. I'm really excited to see the next turn for Geisinger. So we're joining Rise in Health. It was official a few weeks ago. And Kaiser has started this to basically foster innovation. And so we will be a part of a new entity owned by Kaiser that will be a multi-payer situation. So they will be looking for other organizations to come and join us. And I loved when the CEO, Greg Adams, said, I don't see this as an acquisition. I see this as a partnership because we can innovate better together. So personally, I'm really looking forward to see how all that plays out and just being a part of it. And, for the first time in my career, I'm content. Like, I love working in behavioral health. And I feel like there's such a runway, not only for us to catch up to what primary care and others do, we can leapfrog over. So that's what I keep telling my team. Don't just take the default workflow. How can we automate it? How can we do it quicker? How can we not do it? Because our patients deserve that.
So I know a lot of people are excited about like what's going on with that Rise Inc relationship. There's been a lot of interest there, but you're on the inside. What on the horizon would you say is most exciting about that?
I think having more colleagues to talk to about scaling behavioral health. I mean, I came to Geisinger to learn how to scale. We had 200 outpatient locations. I had kind of an internal consulting role first. But now I'm thinking it's like much broader. Like, how do we scale on a national level, being progressive with behavioral health? There's so many community providers, FQHCs, community behavioral health, that all of us, we're not competing for high dollar knee surgeries. Like, we're competing to serve as many patients as possible. So I think scale looks differently, and I'm very much looking forward to being a part of the national conversation.
Well, fantastic, and like what a really perfect way to think about it is like, hey, we have more networking, more ideas, more learning that can happen inside this system. I've got to say, I really appreciate you coming through and sharing a lot about your personal background and journey. I think that it just highlights that, hey, if you're on a unique path, you can still make tremendous things happen.
For sure. For sure. And, my advice is don't stress about it. Just take the next right step. Build your networks, know who you are, know what you like to do, and then just take the next right step.
And speaking of building networks, by the way, I usually ask, like, hey, how can people follow you? But like your LinkedIn profile and posts are so good and so full of positivity and energy that I like y'all just go ahead, type in Don Zieger in LinkedIn or click the link in our show notes and follow. Like there's just all kinds of energy that you saw it today. There's more to come, right?
Absolutely. And I keep saying I'm going to write a book, but I don't think I have that attention span. So what comes out on LinkedIn is just inspirational thoughts about leadership, maybe some things that have humbled me in my journey, and would love to welcome you to join that and even share your own stories.
Very much appreciate that. And honestly, use this as a platform, use this as a network. When we have our LinkedIn lives and stuff like that, that's a really great way to do that too. So I'll have to invite you to one of those at some point. But again, huge thank you for coming in and sharing your story and background.
Gosh, thanks. It's an honor. And I hope it inspires somebody else to take the next step.
Indeed. Oh, and cheat code on that book. Just take those posts. Take.
Yeah, exactly. Exactly. Yeah, but I think the journey is just getting started. I really think this next step with behavioral health, it's the right time to be in this industry.
Fantastic. Well, appreciate everybody who is joining us, and sorry that you could, if you're watching without having been to Future of Mental Health, I'm sorry, but I hope that you got a little bit of encouragement to check it out next time.